Attention everyone, our program will begin in 5 minutes. So gather your friends that are wandering through the halls and bring them back here.
Test.
Okay, we're ready to get started again. All right, our next presenter you heard from briefly before. It's Susan Long, and she's the Director of Clinical and Support Services with the Allina Health Paramedic Service in Minnesota. And Susan, hold on, technology. There we go.
Okay.
All right. So you have the next slide here.
Yeah. Well, good morning again. Thanks for coming back. We're getting started a little early, it looks like. When I first proposed this presentation, I thought, well, I'll come to Las Vegas and I'll talk about what's going on in the state of Minnesota. And I had a whole plan, and then I looked at the agenda and found out that many of my colleagues from Minnesota were here talking about their programs. So that led to some last-minute struggles. But so I'll be kind of quick through some of the materials. Here in the U.S., we have the healthcare challenge. Our population is growing by leaps and bounds. And by 2050, our population, we're going to have the largest group of elderly patients than we've had. We're also trying to find the balance. We have increasing demands from our consumers. They want to be seen quickly. They want to have good outcomes. They want to, we've got decreasing reimbursements. Nobody wants to pay for that care. We want more with less. We also have our increases in our population. People are living longer, and there are a lot more chronic health diseases going on. And we're finding that lack of primary care providers. So even if you want to find a primary care and you want to get your care there, it can be hard to get in. And in some areas of the country, it's hard to even find somebody who's convenient enough for you to travel to. And then for us, we have the Accountable Care Act, which is something of nightly care or nightly news coverage on every media channel you can find out there. And then our EDs are being overutilized. So people are going to the emergency room because they don't have another place to go. They don't have a primary care physician, and that's not the right place for them to get their care in many cases. So it's not working. And it's also not working to say, I'm sorry, we're bombarded by aging boomers, so come back in 20 years. So that's not going to work for us either. So in 2007, Minnesota really started the initiative to help train some skilled providers to become a kind of primary care, provide some primary care in their communities. And we first had a flex grant that was provided by Minnesota Department of Health, and that was just to train 10 community paramedics in this role. Then in 2011, that was successful, so we had the next step was that we were able to get legislation passed by the state to allow those providers to do that work. And then in 2012 was when Allina really got in the mix, and we were part of a $250,000 Jobs and Skills Partners grant to help EMS providers train some people to be community paramedics. We initially wanted to train 100 community paramedics, and we didn't quite get there, and we did actually expand the number of services that we're providing community paramedics to that program. And for those of you who know, that's Dr. Wilcox in the purple shirt there. He's been kind of the champion for community paramedicine across the state of Minnesota. As of 2016, these were the lists of community paramedics that were active and those that were in development, and the list has continued to grow since then. So in Minnesota, we've got about 5.52 million people and a large population of rural patients, or rural population. So first, let's look at the metro. So when Gary Wingrove first started talking about community paramedicine, I visioned it as a rural process. And what we've actually found that is the metro was also very involved in this and has very diverse programs as well. So North Memorial Healthcare was one of the first programs to really get up and running. They're a 2-hospital system. One of them is a level 1 trauma center. They have an ambulance service, and they work in the metro, and they also have some services on the outstate. They have critical care and air, and also have primary care clinics, as most healthcare systems do, and urgent care and urgency centers. So what the brilliant piece is, I think, that North Memorial brought to the table was they actually integrated right from the beginning with primary care. That's one of the problems that we have in EMS, is that when we go into the primary care setting, we don't know what they do, and they don't know who we are. The only thing that they envision us is we're the ones who drive with lights and sirens and go take care of you when you crash your car. So integrating with primary care, the community paramedic actually sat with the primary care staff as they worked through their care planning processes. They were able to document right from the beginning in the hospital and clinic EMR, so the electronic medical record, so that information was accessible to all the people who were providing care for that patient from the primary care, hospital, and community paramedic. Their initial diagnoses were for that MI or CVA patients, some behavioral health, CHF, and diabetes, and they had referrals that would come from all sections of the care team. So they came from the emergency department with those folks that were using the ED for their primary care when they shouldn't be, coming from home care, patients that weren't eligible for home care. In Minnesota, we can't replicate or replace any other provider out there. So if we were going to go out and do what home care did, that wouldn't be allowed by our state legislation. It was actually one of the reasons why we finally got home care folks to get behind the legislation for community paramedicine, because we were able to say, look, by statute, we cannot replace you, but we can help fill that gap. When those patients aren't quite eligible for home care because they can go out to get their groceries every week, we can see those patients. So the initial triggers for North was the patients who were not quite homebound. They have home care within their organization too, and we're able to work with them. Those patients with polypharmacy, the ones that have a grocery bag of medications under the kitchen table and they don't know what half of them are for. And then also their high ED utilizers. So their initial data showed that they were able to reduce utilization of the hospital and emergency care for patients that were in this program. They also looked at utilization 8 and 12 weeks before and after the initiation of the CP intervention and showed a 50% reduction in the ED inpatient utilization. So conservatively, and this is a little bit older slide from them, they were able to look at a comparison cost savings of about $8,500 per patient within that short time frame. So that's within 12 weeks. Imagine if we extrapolate that over a decade, what that would look like. So theirs was the first program in Minnesota to get up and running. Hennepin County EMS is a neighboring service. They are actually share a border. And they are the service that covers primarily the downtown Minneapolis area, and they do have some suburban area. But they cover a population of about 700,000 people. Their initial staffing, they came up with 3.7 FTEs that they were able to fund inside of their system. And what they were looking to do in their program was to increase access to health care. A large population base and the folks in Hennepin County are homeless people. So the community paramedics would have to track those people down which don't have a permanent address. They also wanted to improve the client engagement with therapy. If you get the patient into primary care and they don't follow through on the prescriptions or they don't take the medications or they don't do the follow-up care, that it really didn't do any good, that initial interaction. So they wanted to improve the patient follow-through. They also wanted to decrease the emergency department and EMS utilization. That was a common way people got their care, and decrease the admission and readmission rates. What I thought was brilliant about their program was their Salvation Army Harbor Light process. This is a homeless shelter in Minneapolis, and they were able to get grant funding for this process. They do have healthcare workers in the Harbor Light site, but it wasn't Monday through Friday, 7 days a week, 24 hours a day. So this was an area that the ambulance service would get called to frequently to see these patients. So they were able to staff a paramedic in the hours they didn't have regular health care staff in that particular site, so from 2 to midnight. In the first 5 months, they had 480 patient contacts, so it was quite a busy site. They were able to reduce their unnecessary 911 calls by 7%, and unfortunately, it was a 3-year grant, and they couldn't get that grant funded. So here's a program that has actually shown some data that showed some improvements, but they weren't able to get that funded to go on. So this was the disposition of those patients. The idea was the community paramedic would see that patient in the Harbor Lights and then make a determination about what, if anything, needed to be done. In almost 84% of the cases, the patient just needed an assessment, didn't need any further care. They had about 10 patients referred to EMS. They had about 4% referred to primary care, and they had, some of them they gave bus tokens to. So you don't really need an ambulance to take you to the hospital. Here's a bus token, get on this bus, it'll take you down to the emergency room and you can be seen there. But that was a very small percent. So it's really unfortunate. But they're not daunted. They're going to continue forward. They're still working on their populations of CHF, diabetics, and hepatitis C. That's about medication compliance. They get those patients on medication regime and keep them on that regime. And also doing some lab draws for those patients. And they're now trying to work on how to integrate this into the 911 system. So we have home visits that are happening on a regular case, but is there a way to send that community paramedic out after that 911 call, instead of the ambulance taking the patient in someplace or the ambulance being tied up for a long time? Could they potentially send the community paramedic in to do that referral at that time? So that's another metro system. Now, Scott County is a metro county, but it does have some rural population. And in 2010, Scott County implemented a mobile clinic. This is in conjunction with Dr. Wilcox and some of the folks that you may know from his group. But 3 times a month, the mobile clinic goes to various sites inside of Scott County. It's staffed by a physician, a public health nurse, and a CP. And this has actually been one of those places where we've been able to send our CP students for clinical time to be able to see these patients in that setting. The CP actually sees the patient, creates a plan of action, and reviews that with the physician. In many cases, the physician doesn't actually have to see the patient. They are just relying on the community paramedics' documentation and assessment processes. The physician is needed to write any prescriptions that might be needed, and because the public health nurse is in the same site, they're able to get them referred to other services that they might need as well. When I talked to the individual who helped me with this piece, said they're kind of like an urgent care, and their patients range from, I got hypertension or I need medications refilled, to a patient that's got scabies. And that they hear patients say, I haven't gone to the ED for this. This is where I would normally go because I know the clinic is coming to town next week and I can get to it. So it's been a great training for that group. Scott County has also been innovative in using community paramedics in their jail setting. Now they've got, in a jail setting, you've got a lot of interesting mix of people. You've got healthcare staff on hand, but typically not going to be 24/7. So in some cases, that work would roll down to the guards that are supposed to be doing their duties of guarding the patient or the population. The CPs in this setting work on the same protocols as the RNs. And they have things like the heroin withdrawal protocol, that if someone's coming into the setting and they're experiencing heroin withdrawal, they can actually start them on that protocol. In the past, they would have had to send them to a hospital to be treated and seen. But in this case, they've been able to keep those patients there. Diabetics, getting them set up and working with a sliding scale for their insulin. And their goal is to treat the patient on site and not to transport them. Not only is there a cost with this population of transporting them to the hospital, but think about all the ancillary things that have to happen with a prisoner. Now you need to have a guard staff that need to go with that patient. You take that guard away from their duties at the site. The other thing that's interesting about being in this kind of setting, and you should be paying attention to this if you do choose to use this, is think about the population that you're working with. You might be working with someone who is a murderer, and you need to provide that care just as if you would if they were the president of the company you work for. And so that can cause some ethical dilemmas with some of those community paramedics in those cases, with the biases, the things we think about with the jail population, and the things that they may have done to get there. There's also in the metro area, we have a business that does long-term care support. So how many of your ambulances get called to the skilled nursing facility because the nurses there are new? They don't have a protocol, they can't reach the doctor, and something has happened to that elderly patient who's in the nursing home. So here we're using community paramedics to do essentially phone triage. So the physicians are certainly the folks who are responsible for the care of the patients in that long-term care facility, but the physicians can't work 24/7 either. So by putting community paramedics on the phone triage line, they can cover when those physicians are not available. So that skilled nursing or transitional care staff call in, the CP does the intake for the call, and most issues are protocol driven. If this, then that, we're going to call an ambulance if that's required. If it's not, they have a number of things that they can work through the process and help that nursing staff get orders to take that next step. They still have access to the physician if there are things that are not protocol driven. And currently they're working on with 20 long-term care facilities, and on the hour, the average is about 8 to 10 calls per hour for that community paramedic. So that's 8 to 10 calls in those 20 settings that likely would have either the patient would have gotten no care, or the 911 would have been called to get the patient assessed and transported. So making a huge saving in that respect. Again, when I first heard Gary talk about this, I thought about rural Minnesota was really the place for this this program to work. And we have some interesting programs out in our rural areas currently. The first is in Granite Falls, Minnesota. It's a small town. They have a hospital there. And what they've done with their particular service is they've set up a prioritization rubric for the patients they're going to see. Obviously, they don't have access to see every patient that they may want to see. And they're looking at things like risks for falls so that the CP can go in. And in this particular service, they have a CP and an EMT that go into the system. The EMT helps with some of the things like the safety assessments in the homes and those kinds of things. But they're looking at those patients with a large number of ER visits over 12 months, the hospitalization over 12 months, the number of medications that they have. We hear multiple stories about patients who bring out that grocery bag of medications and say, I don't have any medical conditions, but I have all these, because they just don't understand what's going on with their health care or what their physicians are telling them. I think also the population that we're looking at in this elderly population now, they didn't know or didn't have the ability to question their medical providers in the past. If the doctor said this is what I was going to do, no questions asked. And I see that happening over and over again. So you can see the other areas that they're looking at in their prioritization. In 6 months of enrollment in the CP program, they had 14 patients that they were able to see. Their data showed they decreased ER visits by 64% and hospitalizations by 52%. And they only had one readmission to the hospital within 30 days of discharge. So a huge change for a small number of patients. Their estimated savings in hospital billable costs was over $80,000. Certainly well paid for the staff costs for that community paramedic and that EMT in that case. And over $25,000 in billable savings to the insurance company for the emergency room. And over $100,000 for hospitalizations with only 14 patients in 6 months. Again, think about if you were able to extrapolate this across many, many systems and many months. So their findings overall in medication compliance, including understanding of medications, is less than 10%. And I'm actually surprised it's that high in dealing with some of the folks that I deal with. Most of the patients, or nearly all patients weren't taking medications correctly. They had unfilled prescriptions, polypharmacy, multiple physicians prescribing medications that counteract with each other. And they found that using medication therapy with the pharmacist is key, because oftentimes the physicians will refer in our system back to the pharmacist because they don't know all the ins and outs of those medications. So they'll refer back, and getting them involved is really helpful. The primary care provider is often unaware of that polypharmacy. If that patient is seeing multiple physicians or multiple providers, they're being prescribed by each of those providers. Sometimes they're even using different pharmacies, so that single pharmacist might not be aware of that. So making sure that you get that review done. And of course, as we all know, chronic disease is poorly managed. Patients don't have an understanding of what their chronic disease is and how to manage that. I'm working through that with my elderly mother. She's got some medical problems, and she doesn't understand why this is going on, or that this physician said that, and that's about this condition and not about the other condition. It's complicated by the fact that she's been diagnosed with Alzheimer's, so that's not making it any easier for us at all. So education for the patient, and in some cases I would also add the family to be involved in that education as well. So they sent me one of their case studies. So they had a 72-year-old female who lives at home. She hadn't been out of her home for over 3 months, other than 4 ER visits with non-emergent conditions over the past 3 months, 6 911 calls. She had a history of cancer and believed every ache and pain was the cancer coming back. She called her PCP almost daily for medical advice, but refused to come to the clinic. She had been sexually abused by a doctor 40 years ago, and of course that causes some trust issues for her. So the community paramedic was someone that this person trusted. It was the ambulance person that came when she called and looked for help. So it was easier to get that community paramedic into the home than to get her in to see her PCP. Within 3 visits, the EMS provider was able to get her to agree to see the PCP if the community paramedic would come with her, and agreed that social services could have an assessment, and then she's now received some homemaking services, home delivered meals, and a home care visit weekly. She's had no ER visits, no hospitalization, and no 911 calls. And because of that interaction with the community paramedic, is now seeing that primary care provider on an ongoing basis and able to continue that progress going forward. So a great case study for that particular service. I wanted to make sure people had the contact information for these services as well. So Jana is the ambulance director for the service, is a community paramedic as well as an RN, which is kind of an interesting conversation. When we say, most of us that are paramedics, when we say there's an RN coming to the table, we think, whoa, wait a minute. That's not usually something that we go, that understand each other very well. And so she was a great resource and would be a great resource, and happy to talk to you if you had some questions for her. The other rural service I wanted to talk about was FM ambulance. So FM ambulance stands for Fargo and Moorhead. So that straddles the border between North Dakota and Minnesota. And they have an interesting program as well. They've got one FTE of CP services, and then there's part of an FT for some administration. They told me that their guiding tenets is that their services are intended to be short-term in nature, and they aren't going to provide services for patients that qualify for other care. So if the patient qualifies for home care, they are not going to make that, they're not going to provide that services. So they're, again, not replicating or replacing other services. So they are seeing patients that have that high ED utilizations as well. It's interesting here, and if you think about Luke's data earlier, their average patient population in Barron, Wisconsin was 76 or 79. In this particular area, their average patient population is only 59.9. That's not that old. And largely male patients, or a large percentage of male patients. They've seen an average of 19% in reduction in ED visits and 10% reduction in hospitalizations. Again, that community paramedic is being able to go out there and be a primary care provider to a sense and prevent some of those issues before they become a 911 or a hospital ED admission. 24% of the patients have diabetes, 45% hypertension, a pretty large percent with depression, and 16% have substance abuse, which is identified before they get involved with their care. Their diabetic population, they've seen success with the average of their A1Cs dropping from 10.7 to 8.9, only 6 months after intervention. And their patient that enters with depression has also improved within 6 months after intervention. These are likely patients who have had depression or mental health issues for most of their lives and trying to receive some support for that, but in 6 months the community paramedic was able to make a significant reduction. Hypertension patients who entered the program have an uncontrolled blood pressure, about 159/88 when they enter, and they're down to 128/74 within the following 6 months. Again, very short-term program, but great results that they're able to produce in that period of time. And so Jason Eblin is the community paramedic and the manager of their program up in FM Ambulance, and again was happy to have me share his information and for any of you who might want to reach out to him. So I thought I'd talk a little bit about funding a CP program. In Minnesota, it runs all gamuts. We run from the Regions group that has a grant that funds their process. We have some systems that are doing a fee for service, maybe to the patient or maybe to the physician group that they're actually providing those services for. And in other services, like my own, we're still currently funded by the EMS service. So just like every other paramedic that's on the payroll, the community paramedics are funded by my service. In Minnesota, we've also done some interesting things to try to help support each other. The Minnesota Ambulance Association is the organization that really pushed to get the legislation in place for both the recognition of the CP certification and the payment model. Has a community paramedic advisory committee, which initially met because we were the folks that were going through the grant process together, and we wanted to make sure we all knew what was going on and worked through the problems we were facing as we tried to train those paramedics. but it has now morphed into more of an information sharing resource group, and we meet on a quarterly basis to just find out who's doing what and what are you having success with. Are there groups that we should be talking to try to expand the process of community paramedicine in the state? Also, a shameless plug I'm going to put in here is February 15th and 16th of 2008, we will be holding our second community paramedic conference designed to develop community paramedic CEs for those individuals who want that. There's also a track for management track of how do you manage or measure your CP program. We had one in 2016 and had about 120 people attend in February in Minnesota. It's not like it is out there. And we had people from as far away as Hawaii that came to visit that conference and had really good feedback from the presenters. So if you're interested, you can see me and I can get you some information to find out when and where that is. And there's a second group that is recently formed. It's a CP operations group. So this is largely the people who are managing and running those programs, getting together to solve problems. One of the things that they've been talking about recently is community paramedic safety. How do you make sure when you're sending that person into a home that they are going to be safe in that environment, and how do you help prepare them for that? So there's a lot of great work going on there. In Minnesota, all the programs are very collaborative, working with each other and trying to advance the profession of CP in Minnesota versus I'm trying to get to this before someone else does. So that's been very helpful. The education programs we have, Hennepin Tech was our first program within the state, and now Inver Hills and Century College, and there are a few others that are in the outstate areas that are also collaborating to provide community paramedic education for people. It's still a long process, though. It's 312 hours is what's required by our legislation. About 200 hours of that training is clinical time. So if you think about, in our service, we had full-time paramedics who were also going to community paramedic school. It took a long time to get them through the process. So I think that's going to be one of our next challenges as people start to finally listen to us and say, this is a good idea, we're going to be pressured that we're not going to be able to get people through the process quickly enough to be able to support the need. Another resource that you may or may not be aware of is the Community Paramedic Toolkit, and that was something that was put out by the Minnesota Department of Health, and here are the partners that worked on that. It's a great document for what's going on out there, what are some of the challenges, what are some of the resources. And if you Google Community Paramedic Toolkit and look for the MDH link, you'll be able to download that as well. Another document that you may or may not be aware of is the NAEMT publication about mobile integrated healthcare and community paramedicine. There's another resource for you, and you can get that off of their website as well. So there's more and more information that's out there as things like this continue to happen. People are getting the word out, and people are seeing that this is something that is of value to the industry as a whole. In Minnesota, one of the future expansions, which I'm not really sure what it's going to look like or how it's going to work, is community EMT. Our legislator passed legislation recognizing a certification of community EMT, and that curriculum is currently being written. Because we had in the community paramedic language that you couldn't replicate or replace another service that was already being provided, it'll be interesting to see what this really looks like. The current model that I think the education was going to look like was about 40 hours for community EMT, but there's a lot of interest in our local fire departments in being able to serve the patients in their communities and make sure that they are healthier and being able to stay in their homes longer as well. So remember, if you've seen one community paramedic program, you've seen one community paramedic program, and this is just a smattering of some of the programs that we have in Minnesota that are interesting and different and unique that I thought would be of value to all of you today. So thank you. And these will be posted on the website at some point. Yep. So if you don't get it today, they'll be on the website as well. Okay.
Right. Here, You can put that on. So we will be posting the presentations on the IRCP website. I'll have this morning's posted by this afternoon, and this afternoon's posted by tomorrow morning. We're also recording, in addition to live streaming, we're live streaming this event. It's ircp.info/live if you want to email that to anybody back home. We'll be posting videos from the individual sessions on the website as well. That won't happen this week, but probably sometime next week. And we've also archived many of the previous meetings that we've conducted, the 13 prior sessions. They're available on the ircp.info website as well. So now I'd like to introduce Doug Saka, the chief of the Hastings Quinte. I should have asked you that before. Paramedic service. Doug helps us out. One of the things that we spend some of our time with is adverse reporting system, EMSeventreport.com. And that's a North American thing. And so we collect patient safety events, violence against paramedic events, and paramedic near-miss events, and then publish those quarterly and annually. And so Doug helps us with the Canadian part of that. So thank you for that contribution as well, Doug. And down is next.
Okay.
Up is previous. The one in the middle is pointer.
Okay. Excellent. Great. Thanks, Gary. So thanks for allowing me the opportunity to come and speak today. As Gary said, my name is Doug Saka. I'm paramedic chief in Ontario. And for my presentation, I'm going to walk you through a little bit about a project that we did around the economic value of community paramedicine. And this was a very unique opportunity for us to kind of participate in. At the time, this was actually funded through a federal program. I was seconded to go work for the federal government in Canada as the first paramedic to represent our community in helping to align science and technology research initiatives. So I'll talk a little bit about this study, but I'm going to talk a little bit too just about the relationship piece and sort of the story behind the story as we go through this. I should have listened to Gary and find out which one's which here. There we go. So again, I sort of put this on here so that you have some context, and I don't expect people really to read through all the rest of it, but there's a lot of people that are involved in this, and there's a lot of acronyms that kind of go with this. So on the bottom, there's a number of different ways you can access this report. So we had a specific team that actually put it together. Catherine was our technical writer. Dr. Chris Ashton did the quality assessment tool, active-based costing for this. But if you're trying to find this program or this published paper, it's probably in Google somewhere, and it's probably hidden, deep-fried somewhere in a federal policy bureaucratic folder somewhere. But to get there, you might have to put this number in, or this number in, or this number in. So it's one of those multi-ways of trying to get there, or you could just go to the IRCP website and look at it here, or just take my email and I'll send it to you. So really where this comes about from, and I'll talk just briefly a little bit. So I worked in the federal government under the Department of National Defense, and they actually had a program called Defense Research Development Canada. And the feds, I'm not sure in the US, but the feds in Canada use acronyms ad nauseum to the point where I think it's just for new people when they show up to make you feel stupid, so that when you're there, you really don't understand what everybody else is talking about. And then after the first year, you figure it out, and then they change all the acronyms again. And the next person that comes in, you don't tell them all of them so that you have the same sort of effect on them. So you have the federal government I worked within, so it's part of D&D, Defense, National Defense, and then there's a Department of Defense Research Development Canada. Underneath that is a Canadian Safety and Security Program, which is similar to the Department of Homeland Security. And then within that, you see where this is going, right, is the Canadian Safety and Security Program. So that program actually has $43 million. 90% of that is for forward-facing funding for research. So only 10% is actually used for salary and wages, and the rest is put into research projects around how Canada can become safer and more secure. So I was there to act as the paramedic rep to influence the federal government and help align the paramedic community's priorities with the federal department's priorities. So a really excellent partnership there for 3 years, so then was able to come back. So this economic value of community paramedicine was funded through that program. So a little bit about sort of where we are in relation to the world. So This is our county here. It's Hastings County. Toronto's here. Ottawa's up here. So we're about 2 hours from Toronto, 2 hours from Ottawa. You can drive about 2.5 hours north-south in my county, and then about half an hour across. So one of those long, narrow, skinny municipalities. This project was done in partnership with Chief Mike Nolan, you might know, from Renfrew County, and Renfrew County is just north of us. So between Mike and I, we have the first and second largest upper tier municipalities within Ontario. So in Ontario, the way the paramedic system works is, so you have the feds and the province of Ontario. Ontario actually downloaded the paramedic services to the upper tier municipalities, which is what Hastings County and Renfrew County are. So I've been the chief ever since 2002. And then within Hastings County, we actually have 14 member municipalities, small towns, municipalities that have their own council, and then those mayors and reeves then sit on our county council. So we're responsible for the delivery of the paramedic service, both in Hastings and in Prince Edward County. There's 2 separated cities. We have quite a large geographic area here. Population, 140,000 with everybody included. So just give you some context of that. Excuse me. So this study actually included 200 patients. So our county looked after the urban side of things, so 120 were included in both the city of Belleville and the city of Quinte West. And in Mike's shop, he looked after the rural side. So we kind of had a standard criteria for those engaged, so more than 3 visits to the ER, COPD, CHF, sort of the high users of the paramedic system. They were excluded if they were in a long-term care facility, explained about the difference between rural and urban. And one of the unique factors that we provided in this study was actually looking at a quality of life indicator that Dr. Ashton looked at. So using an active-based costing model, we actually tried to put an economic figure on how much a community paramedic program works and how does that relatively work within the hospital system. So we actually drilled down almost to a unit, what a unit of paramedic time was, what a unit of hospital time was, and actually used those indicators. One of the things that we did at the end was we actually did a Euroqual where we actually did a quality of life adjusted and actually used that in the active-based costing model. So there's some formulas in this paper if you want to take back and look at and how you can actually go through an active-based costing model to look at that. We did include a pre-screening and a final screening, so Luke was looking for some surveys earlier. This study we actually did, and I've got a couple slides at the end that identify some of those. So I'll give you kind of the results first and then talk about the story after. So I basically divided this up into 2 quick slides, one on rural and one on the urban side. So the study basically started here, but we did a 2 to 3 year regressional analysis of the patients in that population sampling. So this was where they sort of started, visits to the emergency room, calls to the paramedic service with those same criteria, inclusion. Started the program here. We had paramedics go and see patients in their home for that entire year, followed them through, and then had a control sample that we didn't tell them that we were monitoring them, but they didn't have a paramedic going to see them, so they didn't really have to know that, and then compared the 2. So you can see what happens in the control group. It continued to go up, and with the intervention of the community paramedic, we actually saw what we would expect to see in the study, where we saw a decreased number of times to the emergency room, we saw a decreased number of times they were calling for paramedic services, really a supportive program within the rural area. In the urban side, we actually saw something that we didn't expect to see. Excuse me. So same sort of regression analysis on this side, but actually we saw a decrease both in the control group and in the intervention group, which is sort of counterintuitive to what the study showed from the rural side. So we actually had paramedics go and see these same patients, but they actually didn't do as well as the rural side. We saw them actually go to the hospital. And when we start looking into this a little bit more, there's a few factors that I think we can kind of pull from this. One is that in an urban area, the likelihood of them wanting to go to the hospital and having it convenient for them to get to the hospital might have actually influenced them going. In the rural side, a little bit harder for them to get to the hospital, so maybe we're more comfortable and relying on the community paramedic to look after some of their treatments. The other thing that was pretty interesting when we started looking through this is just how the actual patients responded to the paramedics on that side. So on the urban side, it was a new program in Hastings County. Renfrew's had a couple different community paramedics going forward. Within our service, this is not funded by, this was funded from a research point of view. There's no local ratepayers funding that goes into a community paramedic. So this is new for us as a service and new for our community. So I'm going to take just a little bit of time to talk about this EuroQual results, because this is a very interesting factor that went through this study. So it's based on sort of 5 different measures: quality of health, so mobility, self-care. And you go through this study, and it's a way for people to actually state how they feel. So I like this quote here. It's basically about a temperature scale. You rate your scale on 1 to 100, 1 being I feel I'd rather be dead than my current situation, or I feel 100% fine. And that scale is actually quite useful because everybody gets sort of a 0 to 100. So the idea was that, again, third party conducted this results for any of the patients that were included in the study prior to the community paramedic starting, and then follow up at the end of the community paramedic. The same questions were asked again, and major improvement in the quality of life that the patients were finding. So it's a unique way of doing it, and then you can actually start using those qualifiers to go through an active-based costing model and then actually come out with a value at the end. So we did see that there was clinically significance, that there was positive quality of life. In the model that we had from a cost effectiveness point of view, this program necessarily didn't meet the cost effectiveness of it. So it's one of those balances, I think, in where you are, the type of program that you're running, how you actually engage in the calculation, really is how you need to look at some of these things. So this is sort of the empirical quantitative data, but I think this really points out the qualitative side of things, where when you start talking to patients on how you feel about your health and how you feel about community paramedicine, and we don't monitor that very well. And I think that's another factor that when we start looking into the political arenas and how we start speaking to politicians about programs. So I'm going to talk a little bit just about some of the survey questions that we asked. So basically, Renfrew County was doing the rural side, we were doing the urban side. So this one talks about how much, if at all, have the community paramedic service provided you, helped you manage your overall health and well-being? And you can see a real significant helped a lot. Certainly between the urban side and the rural side, we see a major shift. In Renfrew, in the rural side, we get a little bit more of a disparity across all of them. So again, a couple things to maybe take away. Again, our program didn't have community paramedicine really before this study. So this is very new for the community compared to Renfrew, but at the same time you can see a real high factor in survey respondents. So here's another one, talks about the overall, how satisfied were you for the services that were provided care by the community paramedic. We've seen it already in a couple presentations this morning, that trust from a community paramedic point of view, and you can see very satisfied to satisfied on both urban and on the rural side in having community paramedics show up and treat people in their homes. So I'm going to talk, so that's kind of the study results, and I really glanced over those relatively quickly, but I wanted to talk a little bit more about this slide here, because this is what it's really all about from a relationships point of view. So I was working up here with the feds under Defense Research Development Canada, and again, this program was providing funding. So you basically had 2 counties. You had Hastings County on one side, Renfrew County. Within Hastings County, I've got 4 hospitals that are part of Quinte Healthcare Corporation. City of Belleville has a stroke center. They have a cardiac center. So they can do those sorts of things. It's not the regional trauma center, though, so we need to go about an hour down the road to the regional trauma center. It's about an hour from our northern hospital, which has 1 doc, 1 nurse at night. Same thing in the south, about an hour south in Picton to get to Belleville, and then a medium-sized hospital about 15 minutes in Quinte West. So that's kind of the geography around where those were. So to have 4 different hospitals all trying to work together just on my side, and then with our service, how we actually relate into this side, and then with Mike's service with the hospitals that he had in his side, you can see where a lot of these things come into play. So what I'd like to talk a little bit about is this relationship here with Hastings County. So I report to a county council of 14 counselors, and this hospital corporation is really struggling, like most, with beds and costs and usability, skill set, retention for physicians in smaller hospitals. They're looking at closing hospitals. They certainly have started to close beds. They've closed floors. They've closed services. We're not funded through the hospital side of things, so it's interesting how the hospital closes, they closed 12 medical admitted beds last year, and we instantly see our call volume increase from the amount of transfers that we now go in our facility because of that. About 5 years ago, they closed reduced their budget, closed a bunch of floors, and shipped all these patients back out in the community, and we just brought them right back into the emergency room and end up in offload, delay, and redirect. So we need to get together and figure out how we're all going to work together on this side of things. So politically, this program was really a challenge amongst our politicians. So we were proposing a community paramedic program, saying, much like this, I don't need to convince this room about how we would become more proactive as opposed to reactive. How can we do things better? How do we work differently? How can we treat patients in the community, keep them safe longer in their homes? And my politicians really took that as a threat, that if we do this, that's going to take away from our ability to keep the hospital open. And so there's this real fundamental shift that I had to help, nurture and keep them going forward with this whole aging population, the amount of demand on our services and how we needed to work through this. They were really, really hesitant in going down this road because they thought if we're funding and doing research in community paramedicine, that it's almost going to support the fact that the hospital could still close and we'd be able to do this. And they were obviously very dead set against closing any portion of the hospital. And so by default, we're not really supportive of this program in the initial phases. So I think it's a good point to bring out when you start talking amongst your communities on how you reach out into these different areas. In Renfrew, Mike has an excellent working relationship with his local health integrated network. They're very proactive. They're very supportive of community paramedicine. They have strong leadership on the hospital side about promoting that. My region doesn't have the same level of support from the local health side. So it's very interesting to kind of see how all these programs actually came together specifically with this study and how we maintain those relationships to keep, one, everybody happy, but two, also that we were working towards the results that we found. So from the study, here's what we basically found. Patient selection was a big thing. We had to get 120 for our side. Mike had to get 80 for his. We had 718 that were part of the original criteria when we looked through that. 485 were in the urban and 233 in the small towns. So that was a lot of phone calls from our paramedics to introduce the program, talk about what we were going to do. And we didn't anticipate some of the responses that we got. So I'm interested in learning how others have identified their community gaps and how they've actually reached out to those patients. So we learned very quickly that we needed to have some support around that. So we were phoning patients, asking them to be part of a study that had died. We'd phone and they might have died just last week. So that was very emotional for the paramedic. All of a sudden now we're in crisis mode, actually talking to the family members about that. So it was one of those, right away we sort of learned we got to be really careful with how we actually go about this and have some support mechanisms in place so that we're actually looking at where we're. So we actually started working with our hospital partners before we started calling to see have these people recently been back in the emergency room, because we might have had data from 12 months ago, and so we wanted to make sure that there could be a lot changed there. We found with these patient set, I think for most of us we can see they were older adults. They were probably on the curve on the other side of the viability of life. So they tend to get sick, die, and then there's new people that come in, they get sick, they die, and so this is a very small window for some of these patients. And what we found in here is that we really were able to extend their life, extend their quality of life as part of that program. So the relationship piece between all these different governments was, I think, the hardest challenge to mitigate. And again, really around beliefs and a common understanding. I think that's the big takeaway for me from this whole study, is about trying to understand the concerns and the relationships that everybody has. So we had federal to municipal. So that was a very interesting dilemma for me when I first got into the federal government, because we went from the feds, then there's the province, and then there's the municipality. And so the feds really only talked to the provinces, and now you had a municipal voice of me talking directly to the feds, which is great for me, but the provinces didn't really like that. Specifically when I was trying to get money to go directly to the municipalities and not to the province. So I learned very quickly, I think, this is great, we get to show up, there's $43 million, and then I started finding out people didn't like me there because there was another mouth to feed at the table kind of thing, trying to steal money from everybody else. So, but a great opportunity because the federal government really good people, but they just don't know what's going on operationally because they're not talking to the right people. So it's a good opportunity for everybody to start sharing that common knowledge. Municipal to municipal, again, the differences between Hastings County and in Renfrew County, my politicians specifically with the hospital and their sort of understanding of where things are going. My politicians have given me a really excellent opportunity to advance our system and do a lot of research. I've been able to do a lot of things in our environment hiding under that research category because I can say it's 100% funded by somebody else, whether it's the feds or a study or the province. So I've been able to move our system forward, but they're very hesitant in entering things without knowing what the ongoing costs are going to be. So part of that education is about showing this economic value of how this is so important based on what we know with our populations. Talked about hospital closures and municipal and the sustainability, sort of those competing priorities. So as far as advice, so if I could do this again, or what would I do differently, or things I think people would really like to know about, we had 13 different organizations involved. They all had competing priorities from where they were going to go. And I think really the common understanding of what community paramedicine is or means is what Susan talked about. You've seen one community paramedic program, you have. So what does community paramedicine mean to you and to your council, to your staff, to your public, to paramedics? It's very different. We could have, in our service, we actually have paramedics that have gone through an educational component. There's no formal process in Ontario for training community paramedics. Other services, 2 counties over, will have their regular staff all of a sudden show up at a clinic and call themselves a community paramedic. Is it right? Is it wrong? It's different, and the problem is that nobody knows exactly what community paramedicine means for that area. So I think this is really important at the very start to understand that, and that really helps with some of the challenges that we would have had both from the patient's point of view as well as from the receiving physicians and that. I talked about how we selected patients and sort of some of the challenges that went through with that. I think the relationship piece was really the strongest thing. I think we need to start expanding who we talk to, start dealing with non-traditional partners, technology, looking how we can do remote patient monitoring, other things like that I think are going to be new areas that is going to expand into our world, and I think we're going to have to start talking to different people that we normally wouldn't have in our tent. I always stress from the research point of view, sort of look at Peter and on the method sides. There was a lot of struggle halfway through this for people to want to change midstream, change the patient population, skew the results so that things looked a little better than what they would. And it took a lot to keep people focused on what we were doing, what the results were, report on those results, and look at how we go forward. So methods is really important at the very beginning to think about how you're going to start these projects and really stick to them, obviously, once you get through the REB process, and then really celebrate the successes. So a lot of this study came out. Some people were kind of lukewarm on, well, there's a benefit in the rural area. My politicians are saying, so maybe this doesn't work in the urban area, and I had to basically say, look, this is one study in one moment in time, and we actually looked at the calculation of the results for the funding on this. Was we actually had all the startup costs included in this first bit and limited to the amount of patients that we actually saw in the study. So it took a bit to, educate them on. So the costing of this entire program was floated up front, and that was included on a limited number of patients. Now that you have 6 community paramedics trained at that level that can now see a wider variety, you're obviously going to see a more cost-effective model that way. At the same time, we've learned a lot from this study, so maybe these aren't the best patients to be seeing in this condition. Maybe we need to see, the patients that are just before they're getting into that cardiac disease, before they start entering into some of these environments. But I think the big thing that I took away was that IRCP study where we actually looked at quality of life, and I think that's what we're all in here for, is to provide better patient care, and so that patients feel better about themselves. and that really came out strong. And I think that was the first time, certainly in Ontario, that we've actually looked at using that type of indicator. So take any questions. That's my contact information. If there's questions afterward that people want to, I'm only here today. I actually need to fly back tomorrow, but I appreciate the opportunity to connect. Thanks.
Now? All right. Okay, Duncan, our next presenter has done presentations for us a couple of times now and has put together a simulation lab in Queensland. And Duncan, we're excited to hear about the advances that you've made in simulation. Did you want to lapel mic or?
Yeah, why not? I'm not good at standing still.
Doug, did you have the lapel mic? Did you use the lapel mic? No. Susan? Yeah. So down is the next slide. Yeah. Up is previous slide. Yeah. The one in the middle is pointing. And we'll have a lapel mic here in just a second.
Good? Yep, no worries. Hi everyone, my name's Duncan McConnell. I am from Australia, so today you've got a few Australians talking today. You'll probably see on some of our slides, a few of us have our cuddly koala. So I do apologise in advance if you get bamboozled by koalas. Okay, whoop, wrong way already. Good start. Okay, so there's a classic picture that was put up already by Neil Kirby. I didn't forget Tasmania, it is right down there on the corner. I'll just point it out just in case, because it is small. There it is. And over here somewhere is New Zealand. Yeah. So a little bit about Australia. We're one of the few countries where you get off an aeroplane and you're greeted with warning signs saying we have animals that will eat you. Okay? That one's out of Cairns. But we have people like that look after our crocodiles. And we've also got some national icons. So being in Queensland, some of our national icons are a little bit more ferocious than others. So we have the drop bears. So it's like a really ravaging koala bear. No, they don't exist, just in case anyone thinks that they do. It's sort of a trick we play to our overseas visitors. But some of our other national icons that help deal with that are people like our own wolverine. So back onto the more serious side of stuff, we're located, well, my particular university is located on the beautiful Gold Coast. That's the home of the 2018 Commonwealth Games. So we're one of the official partners for that. Generally like Las Vegas weather is, just occasionally a little bit more humid, sand and some surf, so more, really it's more like California, I guess. A little bit about me, program director of this new program. We were the last university program to come online in Queensland and probably one of the last in Australia at this stage. We started in 2016 with our first cohort and it graduates in 2018. This is my 21st year working with the State Ambulance Service or Paramedic Service in IRCP language. And I started off as a volunteer and worked my way up to various executive roles, education roles, and then moved over into the university sector. I'm an active advanced care paramedic. I do that part-time in between running the course. But I'm also an active community paramedic as well. The things with those two roles is, depending which hat I have on, depends on what role and responsibility, drugs, etc. I get to play with. So I'm sure there's plenty of people in this room that have worn that hat before. And in previous services where I've worked with the military and private sectors, again, if I'm not wearing those hats, I can't use those skills in there. So I'm sure we've all had experiences in that life. Some of my research interests include the simulation and interprofessional learning, which is what we're talking about today, and also internationalisation of paramedic education and services, which is something that we're talking about later on this week. So, just a little bit about our program. As you can see, its development started in 2014. 15, the CAA gave us our initial approval. 2016, we moved into our first cohort. They graduate mid-2018. And something very new for Australia too is our national registration starts around the middle of 2018. So we're moving across that national body. And David, head of the CAA, he would have a bit of information about that too. So if you want to know what Australia's been doing in that space, there's a few of us here that can let you know. So how does our program work? Well, this is our program. Every university in Australia has its own program. Fundamentally, we're all teaching the same thing, how to become paramedics. Our paramedics don't come out work ready. They go on to a year-long internship to contextualise the training they do at university, and then they're let loose as a fully independent advanced care paramedic. So for our students, their first year is all foundational. So basic skills, basic assessment. Assessing, how do I assess a conscious patient? And then the second half is how do I assess an unconscious patient? So the foundational skills they need to become good higher level clinicians. From there, it's where the rubber hits the road. We get a little bit more advanced. We're going into our advanced ECG recognition. We're thrombolysing patients. We're redirecting people to PCI labs. We're going to advanced trauma education. We're doing other things like that. And then into our third year is where more all about our reflection, future direction of paramedicine, capstone, looking at alternate pathways and where you can manage and transport and things like that. And then finally, and that is actually covered in 2.5 years. So at the middle part of year 3 is when our guys graduate. Their fourth year, which would be the half of the third and half of the fourth, is where they move into that grad year. And that's that internship I spoke about earlier, where they go out, put it all together, and from there, once they successfully graduate from that, then they can continue on as an independent advanced care paramedic. So what I'm really about today is talking about how we incorporate our associated interprofessional learning within the health group. Now, the health group is the big group within this university that I work for that covers all the multidisciplines, be it paramedicine, medicine, nursing, other allied health services. Our paramedicine school is actually inside a medical education school, which is rare in the other paramedic education schools in Australia. There's not many of us that operate inside a medical school. The differences depends on which approach you take, but for us, our main difference is the fact that we do a lot of interprofessional learning and case-based learning. And if there's any other educators in this room, you'll understand just how much money that actually costs. But being in a medical school, it's how they promote their training, so we were able to help embrace that and really provide that more authentic style of educational experience. So the way our health group works with our training is we have our paramedicine group at the front. So your initial call out, what you get dispatched to, the whole pre-hospital experience, that's what we actually are doing with our students and with this program. But paramedicine education doesn't end there. It's all very great that we incorporate this little training inside a room or in an immersive ambient simulator that we'll see a little bit later. But what process happens from there? Well, with our students, we then take that initial scenario, so to speak. So let's pick a particular patient. Our paramedicine students pick their bit, and then from there, we go in and we deal with the nurses. This is where interprofessional learning starts to come within a university environment. They do their ER or ED, emergency department triage, hospital handover, and they continue that hospital journey up to that point. From there, we then move into our medical stool. So our future doctives, our definitive care. So then the paramedics working with the nursing students then do their handover to the future doctors that are going to be working in Australia. And from there, once the doctors do their bit, it then moves over to the allied health side of stuff. And that's our sort of our interprofessional learning pathway that our students do. And you can see that it goes through multiple directions. So just looking at the paramedicine area to start with, we'll just flick this quick video, just give you a bit of an idea of what they actually do.
We're integrated inside the School of Medicine, which opens up tremendous opportunities for interprofessional learning, the simulation like you see behind us, just providing more of a hands-on, authentic training experience, which is what we're trying to get with all our graduates.
We get to use real-world equipment that we would use on road with QAS. Like, it's all the same stuff, exactly the same as on road.
We cap all our cohorts at 50. So enabling our sessionals and our lecturers to be able to spend more time with our students with the really advanced skills involved in this medicine degree now.
The quality of the paramedics that come in and teach us and lecture to us, it's really high and we learn a lot from them. So being taught to be more of an international scope of practice rather than just a statewide scope of practice, which will really benefit us when we look for jobs.
So that was the simulator that Gary was talking about before. That's the immersive ambulance simulator. There's a speech on that previously. We're talking about bringing ambulance units inside the classroom. So that's set up on hydraulics, which aren't turned on just yet. I'm still waiting to get the funding for that because that's the most expensive part of the simulator. But what you could actually see with those windows there, they're actually computerised TV screens which emulate movement when you're transporting. And with all the doors shut, the screens running, the students get that complete immersive feel that they're actually in a moving ambulance, to the point where we've had people end up with motion sickness and vomit throughout an ambulance, so it gives it that more authentic smell. And people actually grab onto things and balance themselves when they get to go up, even doing CPR and things like that. So that even without the hydraulics put on, and our hydraulic motion that we're looking at doing is basically forward movement, backward movement, and just the occasional jolt, so they get that more authentic realism. Now that setup itself has started to be implemented already in Australia. Ambulance Victoria have just introduced a level 1 section of it, so they don't have the screens set up yet and they don't have the hydraulics. But this is the actual environment itself. It can be, that version was a prototype, so there was a bit of expense involved in that because we didn't really know what we were doing. However, since creating that, we've identified key ways of doing it from both a cost-effective way as well as a more simplistic way. So, for example, ambulance services here that operate modules on the back of your ambulance, you could actually detach one of those when they've reached their use-by date, convert it slightly interior if you've updated your change, and you could actually do a similar process. So there are simple ways you can actually adapt some of that training. You don't need to spend hundreds of thousands of dollars. You can actually use equipment that's already there instead of completely reinventing the wheel and reinvest some money that way. So from there, we move into our caring with nursing. So how do we integrate with the nursing, School of Nursing? So for us, the initial patient handover begins. And that's where the students learn their communication skills and learn how to talk to people. When I started 21 years ago, I was young. I still look young, I know. But back then, the average age was about 25. Now the average age is about 18 or 19. And in the current technology generation, they really know how to communicate well with Facebook and Messenger and Snapchat, but they don't know how to talk to people. They don't know how to assess people. So we do a significant amount of communication, education and training, to the point where the course that we have implemented in the course, if they fail it, we kick them out. If you can't talk to people, you can't treat people. That's pretty much a blanket rule. So far, we haven't had any students fail that particular course, and from as much as they go in kicking and screaming, why do I need to learn how to talk to people, while they're standing there talking on their phone to you, once they've done their first clinical placement, they understand the importance of what that course actually gave them. And then from there, moving through clarification of signs and symptoms. So for the nursing students that are learning how to manage pre-hospital patients and the paramedic students learning how to communicate what they've done with their pre-hospital patients, they can learn how to talk. And both nursing educators and paramedic educators then work together to debrief and explain whether positives, negatives, improvements, etc., etc. And then from there, the nursing students complete their documentation, which then moves on to the paramedics using their EPCR. So we've adopted an actual industry standard EPCR that was developed by Beyond Lucid Technologies. Jonathan's sitting up the back of the room there somewhere. And we actually get our students to actually utilise that. So it's sort of like we look at the initial patient treatment as the first stage, and then you do your transportation, you get to your hospital, you've sort of delivered your drugs, you've come up with your provisional diagnosis, and generally speaking, that's sort of where education stops. So what we've done is complete the circle to where the students will complete the complete EPCR. So that's the whole patient care journey. So they've handed over the patient, they've done their treatment, here's the EPCR, that's the scenario completed at our level. But then that scenario moves on from the nursing and do the handovers to then moving on to the medical school. So that same patient then moves on to the medical students who then go through their various aspects of training where they do their triage handover, hospital management, etc., etc. So these medical students actually then spend a week in this simulated type mode with this patient, and they're on call, they're working in the ward, all that type of stuff. And sometimes the patient then gets sent home, and then the paramedic students are engaged again because there's been complications with the discharge. Okay, same patient, new case, new role, we go through the process again. So trying to add that authenticity to what we're actually trying to prepare them for when they graduate. And then from that process, we move into the allied health and other health services that are available. And we have teams associated. And this gives you a fair indication of the other areas within the health group that get involved. So this is a whole of health, a really holistic approach to education. Now, though our program is quite new and we haven't quite launched any of our postgraduate space, which is where the community paramedicine and in the levels of Australia, that's sort of like our intensive care paramedics, our low acuity response, helicopter flight paramedics, that type of stuff. That's where that sort of sits. So as Gary mentioned, in the language that we have in IRCP, the community paramedicine has all those different subgroups. Well, part of that subgroup in that more community paramedicine approach is to actually then engage so that we have referral services to things such as nutrition, dietetics, mental health, fall prevention, other things like that. So that's where we're going to venture in that space in the postgraduate area later on. And towards the end of our degree, we have a course that introduces the concepts of low acuity patient management and redirection opportunities. But again, we only spend a small time on that because the view we've put towards that is community paramedicine in the form like we've been discussing today and throughout this course. It's all very well providing the education to people on what to do at that sort of higher level, but without that clinical on-road experience and exposure to what these patients look like, you're really setting those type of people up to fail. So it's more orientating them with what they can do, how they can call for help, or whether they need to redirect in a different direction. But the whole purpose of this group here in that bigger scenario is that same patient, and then where do they go to those different areas, and what happens if they then need to be redirected. So this is the simulator that you saw the video of before. So as you can see, these are the windows that I mentioned before that all come alive. And once all the doors and everything are enclosed, it really brings it to its own. So the other thing we try to do with our rooms, as well as trying to work inside a simulator, because you can imagine everyone, when they're learning how to cannulate or do certain techniques for the first time, we have like tables set up like this, big bits of carpet, big areas of floor. You've got heaps of room to work in. Okay, so the patient suddenly goes into cardiac arrest in the back of that. Now show me how you're going to push the tables and the chairs out of the way. Show me how you're going to cannulate the left arm because the right arm's got something else in it that stops you from cannulating. Okay, so it makes them think outside. The paramedics in the room, how many of you have been to that case where you've walked in at 3 in the morning and there's blood or diarrhea all over the floor of the toilet? And you've got to try and perform. I mean, what do you do there? I mean, I've seen students start performing stuff inside the little toilet cubicle, but those thinking outside the box will drag them out of that little area to a space where you can actually work. And if there's sort of tunnel vision, they don't know that until they've shown, okay? And I think the beauty of simulation incorporated into your education and training is you can put them in environments that can help them remember later on in life. So other areas we're looking at doing is, and I know some universities in Australia have done this already, is we're looking at providing a more immersive environment. So it's all very well being in a room like this, but there's nothing authentic about it. So we've got cameras set up around the walls, so we can simulate them being inside a pool, or we can simulate them being beside a railway track, things like that. Simulate the shadow of the sun by having a camera coming down on the floor to emulate the ground that they're walking on. So little things like that to try and increase their real-world experience when we're working with them. Okay, so this is another example. This is actually a screenshot of the EPCR that we're actually using that's MedView from Bologna Technologies. So that's what the students will then fill out. So at the end of their scenarios, we get them to fill these out, hand them over. Most recently, they completed their second year respiratory assessments, where they went in as teams to do a respiratory assessment on a patient, be it asthmatic, anaphylactic, COPD, a couple of paediatric cases. They were randomly picked. And then once they completed that OSCE scenario, that end of semester assessment, they then had to complete this for their patient and then hand that in. And that was the end. That's how we ended that particular assessment for each student. Telemetry. So the monitors that we use Core Pulse 3 monitors, and we're looking at other avenues that are a bit cheaper than a $50,000 defibrillator used for training. But the beauty of that, along with our EPCRs, is we actually have used, and working in a Wi-Fi network within a university, we have the ability to start introducing the students to future technology. We're going to send that ECG up to the medical students or the emergency department as they're bringing that simulated patient in. We're going to send that EPCR up to them as well, so that when they're receiving the handover of that patient, they've already got a bit of an idea of what's happened with the patient, what's been done treatment-wise, and what to expect as they walk through the door. Now, I'm not sure if there's too many services. I know some have started to trial it in Australia in particular, but we're trying to provide that next generation of what's going to happen with our care. We aim our program to try and get students to graduate at what paramedics are doing when they graduate. So we're trying to get our students ready for when they graduate in 2018. And there's something big happens between when they start to when they graduate. What do we need to do to recontextualise our programs so they're on board and they're graduating at the same level as what they're walking out to, not graduating with something that we haven't done years ago. Telecommunications, radio communications. Again, we start to introduce it through the first year of their program, but from year 2 and year 3 onwards, requiring same use of radios as everyone else. So radioing the sit reps. If they need to consult outside of their scope, or they need to consult to actually give something indifferent, we have them actually ring up on telephones. And we have real paramedics that work on the consult line, and the occasional doctors too that work in our medical school that participate on that. Now they know what the students are going to ask for, and they actually emulate the same process. So we really engage that whole authenticity of them actually working on road. So we also do a fair bit of agency collaboration. Being a small university cohort size, it does enable us to actually collaborate quite closely with our neighbours and real agencies. So doing things with the Queensland Ambulance Service, so they're working with us at the moment using the simulator. They like that for their high acuity response community paramedics. So these are people that go in there and they do thoracotomies and all types of crazy stuff. So kind of like from HEMS level helicopters and all that type of stuff. So they do really high, and they're looking at utilising this kind of space along with, because it's right across the road from the main hospital on the Gold Coast, and really engaging some of our immersive techniques to help develop and train their highest level critical care or community paramedics in Queensland. And we also collaborate quite closely with the Queensland Fire and Rescue Service. So having our students work in conjunction with the fire recruits so that the fire recruits and the paramedic students can all start to get together and work closely with each other. One of the best things that ever happened in relation to mannequin design and updates with technology was the fact that they made them wireless. Yes, that presents its own set of issues, which I'm sure everyone's encountered over the years with Bluetooth dropping out and things like that. But it is far better than a fire service's jaws of life coming along and chopping your communication cable between your mannequin and your little response thing. The amount of those things I've had chopped up over the years, and the look on the face of the fire, what? So I know all they need to do is put the wet stuff on the hot stuff. So, I mean, things like that are a little bit hard. But I love working with them. They cut me out of cars. It's all right. But we try to instill that. So we, working with the fire instructors, we encourage them, if the students are doing quite well in what they're doing, concepts grabbed, they're moving forward, we look at ways of increasing the technicality of them so that they can experience what it's like. What is it like? And see, I'm quite short, so I was always the one that got shoved in a car when it was upside down, it had to be cut apart. What is it like to have windows explode around you, okay? What is it like to have someone in close proximity screaming at you, telling you to get them out of the car and trying to get them to calm down, okay? So we try, with the smaller numbers, we're able to incorporate that kind of training and technology. Okay, so that's pretty much me. I know I was your barrier between lunch and getting fed, so I hope I haven't delayed your hunger and drinking it too much. Thankfully, I'm not the last person like I originally was, because I would have been your barrier between alcohol and dinner, so that would have been even worse. Yeah, any questions? Yes?
Do you use the military simulation for some of the military simulation models for your explosions and things like that?
Not yet. I have been working in collaboration with Nogra Barracks, which is one of our bigger barracks up in Queensland. And they've got an awesome simulator up in there that they use for some of their training. It's one of the bases before they go over to Afghanistan at the moment. So we are trying to work in conjunction with them, but that presents a whole nother gamut of hurdles as well. That one at the moment, no. Yeah. No, it would be a bit expensive to make mobile. But it's a great idea. It was thought of. Yes, sir. Yes.
And really good simulation stuff. Do they get any experience of real-time ambulance work in that first 2.5 years?
Yes. So at the end of their first year, they go out on their first clinical placement. And that's 6 weeks, full-time, day, night, afternoon shift, fully operational. It is unpaid, as with most clinical placements around here. But within that, what we're trying to now implement, now that Queensland Ambulance has got this low acuity community paramedic approach, because first year is all about basic assessment of a conscious and unconscious patient, we try to get them to spend a couple of weeks in that operational period on road with those low acuity officers so that they can see what it's like to actually spend time at a patient. So my average time on scene in a low acuity role would be about an hour minimum because I go through that full gamut of patient assessment. Our low acuity response that we do in Queensland, again, as Susan said, no community paramedic program is the same. You've seen one, okay? So ours is a little bit different. So we then look at going through, like, if you've met your general practitioner or your local doctor, we go through that kind of level of assessment with them. And in my experience on the jobs that I have done, let's say I see 10 patients a day, maybe 2 of them will end up in an emergency triage department. The rest may end up in a medical centre or redirected or deferred somewhere else. So the beauty of sending the first year students out with those people is they learn how to actually do these assessments, like these very, very concise patient assessments. And then the second year students, they're generally associated with all their operational on-road stuff as well. So, and they do approximately 240 hours in total, and we're in the process of also incorporating our hospital-based assessments, which will include time in the emergency department, time in day surgery so they can get used to shoving things down unconscious people's throats. Being a medical university teaching hospital, those poor patients don't get a choice. And then we look at people like CCU or ICU where they can get used to doing other key intensive aspects as well. Yes, sir.
Hi, Kev Armstrong from Edgeley University. I quite like the interprofessional aspects. Our university will currently exploring the medical school as part of the health programmes. Can I ask though, did you, although you said you're part of the medical school anyway, the paramedic programme set within that?
Yes.
Have you experienced any barriers with the other professions from paramedics moving through nursing and the interprofessional aspect?
No, quite the opposite. In fact, before the program even got up and running, and I attended the first interprofessional meeting of the entire school, if anything, it was when can you start? And I used the term quite loosely to start with, saying, well, yes, we start with our first cohort in 2016, but in the grand scheme of things on skill set and knowledge, the students are basically useless. I said we need to wait till about the end of 2017, early 2018. They've had clinical placement experience, they've had knowledge and been able to apply what they've learnt so that they can actually provide some value-added process to the simulation, because there's no point providing someone that's simulating a paramedic that has no clue how to be a paramedic. Before we came on board, they actually used to get volunteers of actual paramedics that would come in. But with the introduction of our program, it's much more value added for both our students, nursing students and medical students to actually do that process themselves instead of actors pretending to be a set piece of that role.
Do you have combined learning objectives, or do you have a mixture of both for different professions?
Initially, the learning objectives would be set for the pre-hospital stuff would be very, very paramedic specific. But then when they move to the handover process, then you have your mixed learning objectives that nursing and paramedicine will put together. And to some extent, when we work with the medical students, particularly from the consult perspective, we then have joint learning objectives associated with that as well. Good?
We're going to pause for just a second. So a little social media lesson that I got this morning from Chris was, we have 13 times more people watching us on the EMS World Facebook Live page than through the IRCP streaming website. But they can't hear questions when we don't have a microphone circulating. So what we want to do is actually bring up all of the speakers from this morning. If you would all come to the stage.
Grab a chair.
Neil's going to do a little facilitation for us. You can see they're starting to bring lunch in, so we've got until lunch is prepared. We're going to do some question and answer time, but we'll get all of the speakers from this morning up so you can ask any of them questions, and then I'm going to circulate with the microphone that we need for the people watching us on streaming to be able to hear your questions.
How many more?
So I'll take the mic.
Yes, please do.
Okay, so we've got till 12:15, so we've got just about 20 minutes, we hope, of some interaction and question time. So I'll ask all the speakers that were on this morning to come up with a chair. We may need one more chair. One more chair? And Lucas too. Lucas from this morning. Is he still here? Okay. So there's been a lot of discussion, a lot of aspects about community paramedicine this morning, and if you just think back over the speakers we've had, there's obviously a lot of questions that we might need to know. I know in the break a couple of people approached and asked me questions, and I'll respond to one of those questions just to kick this session off, to give you some prompt to thoughts that we might have. I discussed this morning how we're looking at, in the recommendations that were put to Tasmania, that there be a presence of a community paramedic in the dispatch room. And I was asked in the break about what training we give or how do the dispatchers do that. And it's a very, very good question, because when we developed the program and we were doing the review, when we were doing the review and we went to a number of the other ambulance services that have been running these programs much longer than what we have been in Tasmania, they all made the point that the program struggled, the community paramedic intervention struggled, until such time as they put a focused community paramedic in the dispatch centre. It wasn't so much training the dispatchers that's there, the call takers work by MPDS, give it to the dispatcher responds as per the CAD system that they have to respond that. The community paramedic was sitting to the side and would screen the calls looking for what would be a suitable case focused on being a community paramedic. But it raised the issue for me is what is then the definition of community paramedic? That discussion was even had before about what is a community paramedic. And when we're talking about secondary triage, we talk about people giving advice or listening to the person on the phone. I would argue that they're in fact the community paramedic. And the concept, more than the person, of community paramedicine starts from the first time the phone call is taken. I actually describe it this way. When I started as an AMBO, as we'll call it, in fact, I started as a driver-bearer. In 1978, I was a driver-bearer. That's better than being just a driver, because they were just bearers. But you could be more advanced and be a driver-bearer, which I was, which was really good. But we we would often arrive at the hospital, and that was the first the hospital knew we were coming. So the front doors of the hospital were where I backed my ambulance up. We took the patient out and we went through the front doors of the hospital. By the 1980s, 1990s, that had moved. The front door of the hospital had become the back of the ambulance. There were decisions being made by the paramedics in the back of the car as to where or what the patient would enter the healthcare system. So that became the front door of the hospital. I'll put to you now that we're at a point where the front door of the hospital is the call taker that takes the call. From the time that call is taken, the person has entered the healthcare system. And that decision about what pathways they enter on starts at the time that call has been taken. So the concept of community paramedicine needs to extend right to when the call is taken, and there needs to be that expertise in the comms room. So that's the response to the question that I got in the break. So let's open it up to any of the speakers here for other questions, please.
We do have another question for Duncan.
For you, when you're talking about that in triage, do any of the agencies use like a mobile critical care nurse or something of that nature in the dispatching center so they can triage someone, maybe somebody with 30 years of experience in like surgical ICU nursing or something of that nature?
And the experience that I've seen in the Ambulance Victoria is, yes, they do. They have a mix there. They have both paramedics and nurses, particularly with triage experience and so forth.
Perfect. And for the one gentleman with the simulation, have the students ever been utilized as standardized patients? Maybe a little money for them?
Simulated patients, you mean?
Correct.
Yep.
Actually playing the role of the simulated patient. So the medic learns through osmosis almost.
Yep. So with their actual clinical assessments that count towards their final grades for those courses, we will use either a simulated mannequin or an actually trained simulated patient. However, our semester periods go for 12 to 13 weeks each, and during that period they will actually take turns at simulating both the patient, the partner, and the paramedic themselves. And just on your topic before with low acuity, with the community paramedics, in Queensland, when we work on road as the community paramedic, we actually rotate through the communication centre so that we spend time with a dispatcher who does all the call taking, and then we can provide the clinical perspective, and then they dispatch the most appropriate units. So that's how we do that side of stuff in that particular state.
Okay, question from the floor. An Irish question.
Thanks. Just a question for Duncan as well. Thanks. Just in relation to the simulation and the training, very interesting. I was just wondering though, in relation to driver training, I don't know what you're mandated to do over in Australia. So does driver training take any part of the actual course itself?
Officially, no, but we have purchased 2 ambulances that the Dean of Health is very keen for our students to experience at a local driver training facility. However, when they do their graduate year, ambulance services send the students out on an official sort of 3 days to 1 week driver training program. So that's generally in Australia handled by the individual service themselves.
Okay.
Excuse me. This question would be for either Lucas or Susan. What cost recovery challenges have you accomplished or come across with your systems?
That's a great question. I'll talk tomorrow about our individual program at Allina Health, and we currently are funding all of our community paramedic time through our EMS operation. So the hospital or the primary care provider who refers to us has no financial cost to them. We are going to be, with our program, we're going to be finally able to get on the same EMR as our hospital and clinic side is. We've been able to access it and write a telephone note in there for the past 6 years or so, and that has finally been changing, that we will now be billing for those community paramedic services in certain cases. We do have legislation that allows us to bill Medicare, and there's a rate set up for that. So currently our EMS agency, because we are a very large agency and we have a great economies of scale, we're able to absorb those costs, and we have about 3.4 FTEs of community paramedic time right now that we're providing. but we're also part of the overall system. So while it's coming out of our department budget specifically, at the end of the day, those dollars all go back to the entire Allina Health system. So we see it as our way to give back to the system and make the system more efficient.
And Luke stepped out to take a call, but I can answer for him. We're the same way. It's self-funded, but part of the system.
Duncan, just a question for Duncan. Sorry, Duncan, I know you've had a lot. Just going back to your simulation, we're from Edge Hill University in the UK, and we use quite similar simulation techniques to yourself, which are fantastic. But one of the things I wondered if you considered is using service use carers, service users and carers patients in terms of your simulation rather than students or actors.
Yes.
Because we found great benefits from that. So.
Yeah, it does. And these people that are used, they're the same, they go through an actual simulated patient training program run by the medical school. And it's not just paramedics or medical students, the nursing students use it, the allied health students use it, so that it's a big gamut. And the type that you can gather simulated patient-wise is actually quite huge. We've even gone down to the point of including actual transgender applicants as well, so that students can get people simulating various aspects across the whole gamut. So it's a big process. It's loved by the students. It is very expensive, but it works quite well, very value added.
Just while we wait for the next question from the floor, I'm going to ask a question of both Susan and Doug. It's a question that's been put to me by many of the politicians that we deal with. Why can't we just teach community paramedicine skills to our paramedics? Would you like to give me an answer for them?
What I would answer to that question is that it is a different, not every paramedic is designed to be a community paramedic. When we take our paramedics and we put them in a 911 truck and we send them out to that emergent call, we primarily expect that they're going to transport the patient to the hospital, or at least offer that in our service. So rather than coming in and saying, what do you want us to do about that, we ask, which hospital do you want to go to? We reverse that role with the community paramedic. The goal is not to go to the hospital, but to try to incorporate those things into their home, into the care, the education they're getting at their site, to keep the patient from having to go into the hospital, but also being smart enough to understand where that line is that you're going to cross. That patient really needs to go to the hospital. And so I would just say not every paramedic is designed or qualified to be a community paramedic. It all depends upon their mindset, their ethics, and a little bit about their gut reactions to what that patient needs, and being able to be an educator for that patient, an advocate.
Great. So in Ontario, paramedics aren't self-regulated, so I think we're the most heavily regulated, non-regulated healthcare provider. So for us, it's really around some of the skill set. So the way the current delegated medical acts occur in Ontario is that there's a physician that delegates and is only allowed to delegate supposedly specific skills within that legislation. The challenge is some docs go off script, which is typical. At the same time, it becomes a challenge because I'll have paramedics that work for me full-time that work somewhere else part-time, and vice versa, where they actually have different standing orders, even though they're supposed to have one standard skill set. So we have basic skill sets, advanced care paramedic skill sets, and then think from the community paramedic side, there's a little bit additional training and a little bit more in that geriatric assessment that could allow for some different delegation. So for us, part of it is legislation. We basically got around that by having our community paramedics not fall under the current legislation, and so by not having a self-regulation, we can hire our own doc and then have our own skill set based on that.
And Doug introduced a new term, paramedic self-regulation. We actually have a speaker addressing that this afternoon, so let's hold the questions for that till this afternoon.
So West Virginia has standardized community paramedic protocols, just as they do other places. I think West Virginia is one of only 4 states that has standardized practices across their state. Does anybody have standardized community paramedicine procedures or protocols out there that they've seen? Okay, so it is totally at a local level. Okay, so the follow-on question of that, the people that have won the special innovation grants or the proposals, can you talk about the pitfalls of that or the goodness of that?
So I can answer a little bit on that. So within the federal program that I was involved with, we actually created a standard around community paramedicine. And it was worked with the Canadian Standards Association, had a technical advisory committee that worked it out, really to identify sort of those buckets and then start filling in some of those processes. So we're getting there. At the same time, they're voluntary standards. There's not something that's certainly mandated. They're not enforced. I don't know who would actually be the one enforcing it, but really it's about trying to go down that path because we're starting to see exactly what you're talking about. Community paramedicine in one place is different than the other, and we're trying to get at least sort of that baseline. I think through conversations that we've seen through IRCP over the number of years, we're starting to see where those common areas are. Something I can certainly share with Gary and the group from that side.
Other questions?
So I have one for Doug. If you did your study on your call about the actual patient, did you look at anything about the caregivers for those patients? So what their quality of life was, and then also any training for them?
Yeah, good question. So we didn't do the quality of life on the caregiver, but we certainly asked about the caregiver from the patient's point of view. So how much of a burden did you feel you were? And that was a big thing that we found. There's a lot of patients that are worried about who's looking after them and the amount of pressure or burden that they feel that they're putting on those family members and that. So part of our questionnaire incorporated that side of it, but we didn't specifically go and look at the separate caregiver provider.
Now, one thing is cruel is to sort of hang out to lunch, but it is really, really cruel to fill the room with the aroma of lunch and then still hang out. But we're going to take two more questions. We are still well ahead of the allocated time. So two final questions before we break for lunch.
So this is for everyone, but in particular, I was going to ask this to Lucas after his talk. And for me, I was speaking with a chief out of Dallas, Chief Gomez, one time, and he was saying that he underestimated the post-visit work done by the paramedics within the unit to follow up. To save on windshield time, there was a lot of calling that was occurring, and they were not reaching their patients and so on. So the question is, how much of that work exists in your programs? We always talk about the call. We talk about the run to go there, to be there, to provide care. But how much is there back office function that it has to be considered when building a budget and trying to document worth?
I'll try. So the good news and bad news is that our program is not super busy at the moment, even though we're in a big system. So we found that our average community paramedic visit lasts about an hour and 15 minutes. And we probably have as many as maybe 4 to 6 calls per day, depending upon which days which patients are scheduled when. What is really more of our struggle was being available for when those providers were going to make referrals to us. So we've had to staff for the demand of the provider versus staffing for the demands of the patients, although we have tried to kind of make some adjustments. For a while we were doing hospice backup, so when the hospice nurse couldn't go out, but someone needed to go out, they would send the community paramedic. And so we had a lot of downtime in those particular situations, and we've actually backed away from some of that because the productivity was so poor and didn't make sense for us with the number of calls that they were actually sending us out. But I would say that they're probably spending about as much time in the prep and the follow-up after the visit as they do on the visit. So it's probably about a 50-50 split in our particular agency. And as we change to our new documentation models here in the next few weeks, it will probably be a lopsided.
Kevin, you're a community paramedic who's probably been doing it the longest, certainly of anybody in this room. Do you have anything to add to that?
Sure, I would say that I would say 50-50 is probably a good bet. Some of the patients are actually more like 70-30, depending on not just the follow-up back with the patient, but also follow-up with their home care their primary care physician and linking them into other places. And so a lot of the phone time post-visit will have to do with other agencies that we are trying to get back involved, and also talking with the family members that we deal with on these patients as well. And so I would say for an hour visit, we might spend 4, 5, 6 hours at times. And a lot of that, as someone who runs the program, I also do a lot of that on the weekends and at night. I get patients who will contact me through the office, or then the physicians will call me at night on the weekends as well and ask questions about how things are going there. So there's quite a bit.
What year did you do your training?
When did I do my training? 2010? Yeah, 2010.
Okay, well, I think that might wrap it up. We have lunch. It's a good opportunity to interact on these discussion points, so we'll try and be back. So 1 o'clock, lunch is served over here, and we'll be back and start a sessions for 1 o'clock. Thank you.